Hello, everyone. Welcome to Asian Novel Seminar, hosted by Arthroplasty Society of Asia. This program is designed to establish a professional arthroplasty forum that joint surgeons from all over the world can be connected to share their personal ideas, clinical experience, and cutting-edge technologies. I'm Wen Liang from Beijing Chaoyang Hospital, Capital Medical University. I'm honored to moderate today's discussion. In today's program, we will focus on some new alignment methods and novel technology in total knee arthroplasty. Total knee arthroplasty experienced its greatest development in 1970s, with mechanical alignment becoming the gold standard. But since then, although various new prostheses, more precise implant tools, or new technologies have emerged, unfortunately, there has not been a milestone progress which significantly improved the post-operative outcome of total knee arthroplasty under the preconditions of mechanical alignment. It's interesting that fewer and fewer knee surgeons are stiffly sticking to the 3-point line post-operative HK alignment. Instead, more and more knee surgeons are focusing on restoration of native joint line, less soft tissue interference, and higher patient satisfaction. In today's seminar, we're honored to have 3 highly experienced and renowned experts in the field of artificial knee joints. They are Professor Stephen Miller-Hall from a biomechanical department of University of California, Davis. He is a leading expert and pioneer in kinematically aligned total knee arthroplasty technique. Welcome you, Professor Hall.
Thank you very much, Dr. Wen.
And Professor Huang Wei from the first affiliated hospital of Chongqing Medical School.
Hello, yeah.
And Professor Zhang Guoqiang, he comes from a Chinese PLA General Hospital in Beijing. Welcome you, Professor Zhang. In the following 1-hour seminar, 3 experts will introduce their own unique technique in total knee arthroplasty. Professor Hall, thank you and welcome to Arthroplasty Society of Asia again. I remembered at the second episode earlier this year, you gave a masterly speech on Calipered kinematically aligned total knee arthroplasty. But for some knee surgeons who have begun to try KA technique or prepare to try, still have some concerns. As a doctor with more than 5,000 kinematically aligned total knee arthroplasties, your experience and sharing will give us clear answer to these concerns. The following time is at your disposal. Please.
Thank you very much, Dr. Wen, for inviting me to speak at the Asian Arthroplasty Association meeting for the second time, and I'm honored to be here with the other co-speakers to discuss alignment techniques. And my topic is, why can unrestricted calipered kinematic alignment be used for essentially all patients with osteoarthrosis, and how would you do it? These are my disclosures. I'm a consultant and receive royalties from Medacta and total knee arthroplasty, and then I received some sports medicine consultancy and royalties for sports from Zimmer Baumet. I also have a new textbook co-authored on Calipered KA that comes out this month with Elsevier. But what I'll talk about is an open source initiative, meaning that principles can be applied to pretty much any technique. The talking points I'd like to cover is that calipered kinematic alignment restores the patient's prearthritic joint lines, and it does so actually more accurately than robotics, navigation, and PSI. Not that those other techniques aren't accurate, it's just that our technique is more accurate. The risk of varus failure, which is a big concern, is negligible with kinematic alignment and higher with mechanical alignment. And then to illustrate these points, I'm going to show 3 cases of mine that taught me a lot. One is a severe varus deformity, another is a severe valgus deformity, and one is a multi-level deformity treated with unrestricted calipered kinematic alignment. So let's talk about the first one. Just get on a common page. Our target is restore the patient's prearthritic joint lines. And you need to understand that if we look at these poses of the knee in the schematics, there are three axes in the knee about which the tibia and patella flex and extend and internally rotate. And these axes are either parallel or perpendicular to the patient's joint lines. So when you want to restore kinematics and do kinematic alignment, you want to restore the axes of the components and co-align those with the native knee. And you do that by simply resurfacing the knee, as you see here. Calipered kinematic alignment sets components like a dentist place a crown on a tooth. When they put a crown on the tooth, they don't look at where the ear or the chin is. Like when we do kinematic alignment, we don't look where the femoral head or the ankle is. And then we, just like the dentist, look at the joint surfaces only. You really don't need the x-ray in the operating room to do the technique. We do screen the radiograph for hardware and bone defects and signs of laxity, but the centers of the hip and ankle are ignored. The target thickness for our technique is the thickness of the distal and posterior femoral condyles of the component. So in this example, if the component's 9 millimeter thick distally and 8 posteriorly, our distal resections from the femur should be 9, our posterior resection should be 8, but that's after we adjust for the thickness of the kerf of the blade of 1 millimeter or so, and 2 millimeters when there's cartilage loss. An accurate technique is defined as having no mean difference and a 0-degree standard deviation from the target. So if you play golf, your 3 balls, if they're all to the right of the hole, there's a high bias, but good precision. If you hit the ball short, left and right, then you have no bias, but poor precision. So what is an accurate technique? One in which there's no mean deviation and a 0 standard deviation. All the targets are hit. So we did a study in which we looked at the distal medial, distal lateral, posterior medial, posterior lateral resections. And the most accurate technique is one in which there's no difference and a 0 standard deviation, as you see here. We had 10 surgeons that were experienced perform 203 knees, and you can see we had a very low mean difference in standard deviation of about 0.4 millimeters. The less experienced surgeons that had only done up to 50, little more bias, but also a low standard deviation. The robot, at least by Rosa, little higher deviation and higher standard deviation. And another study by the robot shows the same, and PSI. So it's not about which technique is totally more accurate than the other. You can take to the bank that the calipered, unrestricted technique accurately restores the patient's distal and posterior joint lines without referencing the femoral head or ankle and without the need of looking at the x-ray to do it. Now, this is the main point. What's the risk of varus failure with kinematic alignment? Well, MA changes nearly all joint lines, which explains the high rate of varus tibial loosening. You can look at Hirschman's work on the phenotype published 2 years ago. This schematic from their article shows that 85% of femurs that you're going to place in mechanical alignment are in varus to their native joint line. They're in varus. When you do calipered kinematic alignment, we don't put the femoral component in varus or valgus because we restore the patient's prearthritic joint line. Let's go to the tibia. It turns out if you do a normal population of OA patients with mechanical alignment, you place 70% of those tibial joint lines in valgus to the patient's prearthritic joint line. And when we do calipered KA, we put no tibial joint lines in varus or valgus because we restore the native one. Now, this is one of my own examples. This is a patient that had a calipered kinematically aligned TKA done in June of 2007 on the right. The femoral component is at 7 degrees valgus to the anatomic axis. It restored the patient's prearthritic joint line. 6 months prior to that, I had done the left total knee with mechanical alignment, and that femoral component is in varus. And there you can see the sign of osteolysis or loosening. So KA has a very similar risk of tibial component migration compared to MA at 2 years. So you don't have to be worried about this process causing varus collapse when you do it in an unrestricted way. And this RSA study, radio stereophotogrammic study from Michael Dunbar, showed the settling of the implant was negligible with KA at 2 years. And this is further brought out to allay your fears by Klassen's article, where they looked at the failure at 7 years between KA and MA by combining the New Zealand and Australia registry data. And they found at 7 years, the KA triathlon that was put in at that time with PSI, which is less accurate than what we do now, had the same revision rate as all the other triathlons that were put in, presumably with mechanical alignment. And this was a non-designer study. So armed with this information, we know that the technique is accurate. We know it's simple because you use a caliper check to place your components. Let's look at some severe deformities. So here's an example of an unrestricted caliper KA restoring the joint lines in a severe varus. And this is what the patient's x-ray looks like. And this is what it looked like when we opened the knee. And you can see the notch is stenotic, the ACL is missing, but there's very little wear on the bone actually at 0 and 90 because the knee has a flexion contraction. So at 0 and 90, the bone is generally there, and you can use that to build back from. Now, we use a distal referencing guide that says worn on the worn side and unworn on the if there is no wear on that side. And then we make our cuts, and we measure them as we go. And if we're off by a millimeter, we'll adjust it, either take a little more off or shim the 4-in-1 block out and fill the gap with cement. We then use a 0-degree posterior referencing guide, and we make the measurements of those resections as a double check. This was the actual time to perform the incision to the completion of the femoral cuts in this patient's case, which was 8 minutes. So it's very efficient time-wise. We also record the values of the cuts in a interoperative verification sheet so that we can keep track of our surgical technique. We mark down the thickness of our distal femoral resections. We make any markings of adjustments that we make. We mark the posterior femoral resections and the thickness of the tibial resections. These values to me are so important that I also make sure that they're put in the procedure section of the operative note. So I know if those cuts were right on the femur, that if there is a problem post-op, it's usually an error on my part in varus valgus cut, slope, or insert thickness of the tibial side. This gets a rapid recovery, which is what Dr. Wen was talking about at the introduction. And it does so by restoring the patient's joint lines. So this is the patient at 6 weeks when he comes in the office, and I don't use physical therapy any longer because these patients can do their rehab quickly and easily on their own. This is what he looks like walking. The varus thrust is gone, and he has a relatively normal gait on that side at 6 weeks. When you do assess alignment with a radiograph, it's not always that helpful, but if you want to, make sure you image both knees at the same time or both limbs at the same time. Your target is to match the distal lateral femoral angle of the opposite side and the proximal medial tibial angle of the opposite side within a degree or two, because there is a little bit of side-to-side variability. How about the valgus deformity treated with unrestricted KA? I learned this back in 2006 when I did this patient. She's now deceased. And I got this postoperative limb. And I thought, oh my goodness, I left the knee in too much valgus. But when you look at her standing, she's native. Alignment is in valgus. And when we look at the postoperative achievement and compare it to the opposite side, we restored the distal lateral femoral angle at 94, the proximal medial tibial angle at 94. So we left her limb in 8 degrees of valgus, but the opposite leg is in 9 degrees of valgus. That alignment is who this game warden got bit by a crocodile and sustained an open femoral fracture. And I learned a lot from this because you couldn't do mechanical alignment on this guy, as you'll see. Here's a picture of his leg. Here it is from the medial side, showing this large, free vascularized flap that was necessary to heal his infected non-union. That's only flexion he had at age 52. And when you look at the x-ray, there's a medial wear. It's a femoral malunion. You'll see in a moment that's a huge angular deformity in the sagittal plane. He has patella baja. You can't use an IM rod, and you can't correct this with NAV or robot. So we had some exposure issues because of the patella baja. We did a tibial osteotomy, tibial tubercle osteotomy. We put it back, and he had a rapid recovery, which is what you get with unrestricted Calipered KA when you restore the patient's joint lines. This is him at 5 weeks. He has a short leg gait because the femur healed shortened, but he can walk without any assistive device. He had no physical therapy. He can do a squat. And then if we look at him from the side, he's got pretty good control at 5 weeks. And that's about the same flexion that he had pre-op, and it won't get better because it's been limited for so many years because of the bite. This is what it looks like. The osteotomy is healed, and he can still walk at 10 years, 10 miles a day, a couple of days a week as a game warden on uneven ground. His Oxford score is 44/48, and this is what his leg looks like. Huge varus malunion, but because we restored the patient's joint lines, the knee is balanced and really does not have a high risk of varus tibial loosening, which it would have if you did mechanical alignment in this patient. And you can see the deformity here. So to summarize, restoring the patient's prearthritic joint line enables the patient to have a rapid recovery, and in our experience, without the need of a physical therapist who can push the patient too fast, too hard, and make the knee swollen and sore. This is an example of a patient whose activities I did not condone. He was a very healthy fella. This was the bad knee that he did. We fixed it, restored the angles, restored the flexion of the minimal flexion of the femoral component, restored the slope. And this is him at 6 weeks after having his total knee replacement done. And I had to check the time and date on the video to the date that we did the surgery to confirm that that's actually what he did. So I am not advocating this. I'm just showing you what can happen. In the long term, here's a guy that I treated with varus wear. He enjoys running, and he can run 5 and 10K races at the age of 68. And that was an example at 2 years. So I want to thank the Asian Arthroplasty Association and Dr. Wen for his invitation. This is a commercial a thing, not because I'm going to receive great royalties, but I want to educate you. There's a new textbook coming out this month from Elsevier called Calipered Kinematically Aligned Total Knee Arthroplasty, 19 chapters. Most of them have videos that go along with each subsection of the chapter that you can learn from, and I hope that you find it an educational experience. I always like to close by thanking my co-worker and a partner in crime, as we say, distinguished Professor Maury Hull, who I've worked and collaborated with for 30 years, and my new young partner, Dr. Ned Appeal, whose name you will see on a lot of papers that we've done on calipered kinematic alignment. Thank you once again.
Thank you, Dr. Hull. Very much indeed. I think we are looking forward to new books. Okay, let's sit back and continue to enjoy. Now, let's welcome Professor Huang Wei. As a leading orthopedic surgeon in Chongqing, Professor Huang Wei has always been known for his preciseness and excellence in knee surgery. Please invite Professor Huang to introduce his experience in total knee arthroplasty. Please.
Good evening, everybody. It's my honor to attend this seminar. And so lucky. And I can discuss with Professor Howell. Today, my topic is computer-assisted bone resection, the key to precise TKA. For successful TKA, we need to pay extra attention to the following points: alignment, bone defect, flexion and extension gap, joint line, and soft tissue balance. Whatever procedure use gap balancing or measurement resection technique. But for a successful TKA, a stabilized knee is one of extreme importance, which include two aspects: bone balance and soft tissue balance. And now we think bone balance is more important. In the past, we always emphasize that TKA is a soft tissue surgery. However, with navigation and robot development, we can perform accurate bone resection and achieve mechanical sound alignment and decrease soft tissue release. So these are commonly used protocol for gap balancing. However, different patients have a different parameters and the soft tension, and a different doctor have a different technique. So, in our study, we analyzed the morphologic feature of the knee by race and gender. So we found there are significant difference between European and Chinese, and between men and women. As we can see the figure above, the red dots signifying Chinese are many on the left side, while most of the blue ones indicating Europeans are on the right side. We also find the current processes cannot match with the Chinese and the European. We can find the 9 processes are poorly matched to the needs of the European and the Chinese population, especially Chinese. Why is this so? In TKA, the processes is not designed based on each patient characteristics. Instead, for good function, the patient's anatomic structure need to be cut to fit the prosthesis with prototype size. So we can find maybe such as a very simple structure, medial epicondyles, femoral condyles. We find there are 3 types of the epifemoral condyles. So they usually epicondyle only account for 60%. So in this continuation, it tells us the prosthesis needs to be tailored and refined according to each patient. So for this reason, we started to do some navigation and the robots. This is one of the photos of the performance surgery with brain-enabled navigation in 2021. Since our team has performed several orthopedic surgery using navigation or robots, we realized navigation or robots can create a new path for TKA surgeons with pre or intra-operation. We can conduct precise bone resection and obtain sound good mechanical alignment and decrease the soft tissue release. So the patient may experience less pain and quickly recovery of joint function. Now, I will tell a case. A patient is a female, 69. She has a severe osteoarthritis with valgus deformity, classified into Real-Water 1 type 1. According to the X-ray, we found there is 5 degrees of the valgus deformity and a slight subluxation. You can see a slight subluxation. For every patient before the operation, I always check the ligament function at the 0 degree and 90 degree. So now we can find the patient, the function is good. The medial has a little tight. We also do some stress test at 0 and 90 degree fractions. It's also the same. This seems a simple case. So we would wonder, is this another conventional TKA? This we can find the brain level navigation. We make patient registration pretty quickly and easy. We only cost to the 5 minutes to register. After registration, we found this patient had a 8-degree of valgus deformity in deep fraction. At the extension, she has a 3-degree valgus deformity. So now we check the full functions. It's also find the lateral side is a little tight at the extension, but in 90-degree fraction, we can find there is lateral is loose. So after all this measurement, computer tell us maybe we should use size 5 femoral prosthesis. However, now we can find there is a large amount of the posterior femoral condyles needs to be resected. So it's too large. There is a large fraction gap. Maybe we should change to the size 6. Now we can say maybe it's better than the size 5. But there is another question. Before operation, we do a templating. We find size 4 is small in AP diameter. Size 6 is too large in ML diameter. So in this conversation, we have to choose size 5 prosthesis. How did this happen? That's because the implant is mismatched with patient's anatomic structure. The ML AP ratio of size 5 and size 6 implant are 1.13 and 1.11. But the patient's structure ML AP ratio is 1.21. So it's matched. The patient's structure is mismatched with the prosthesis. So considering the fact we place the implants 2 millimeter posterior translation, and in this situation, we can decrease 2 millimeter in condyle resection and 2 millimeter less in fraction, just like this 2 posterior. So the fraction is less than 2 millimeter. Second, because the implant was moved posteriorly, a notch may be produced. Therefore, to avoid this, we increased femoral fraction to 4 degrees or so. Now we can find the another 1.5 millimeter less in fraction gap. The third step, for this map, we can say the lateral gap is greater than medial gap in fraction. So we can use external rotation and increase to 5 degrees. And the fraction gap was reduced by 1 millimeter lateral. So now it's equal than before. The fourth step, there is a basic balance was achieved as the fraction and the extension. However, we can find that there is a 30 millimeter gap, so it's too large for an effective TKA. Now, we did 1 millimeter less in the tibial resection. So the gap, flexion gap and extension gap change to the 12, and so on. The fifth step, after that, we can see the lateral gap was unsatisfactory. So the vargas angle was increased by 2 degrees. And now we can find the anterior, the lateral is better than before. For this map, we can tell the flexion gap and the extension gap was still large. There is 12 to obtain a more balanced, more effective gap. So we do one more decrease the tibial resection 1 millimeter down. You can find the gap decreased to 11. Now looks good. We started to perform the operation. As you can see, after prosthesis installation, we didn't release any soft tissue. Now, in extension and flexion, we achieved a sound flexion and extension balance. The ligament is good. The stabilize is good. This is a table of surgical data. It reflections with the navigation. The surgery is much more precise, only maybe 1 or 0.3 millimeter different. After surgery, the X-ray shows an increase of the 2 degree vargas and 5 degree flexion, which is consistent with the pre-operation plan. And the mechanical axis is good, close to normal. Now we can see after operation, the first day post-operation, the patient's function is good. The ROM from 0 degree to the 140 degree. Now the function is good. He can move freely, but a little pain. He can also work with the supporter the next day. After 2 days, her pain was relieved markedly, and the function is good. He can walk friendly. He can move friendly. We can see he smell and walking. For this case, we learned that even for a simple TKA, the discrepancy between patient's anatomical structure and the prosthesis are often challenging the surgeon. However, through precise bony resection with navigation, the soft tissue can be preserved and the gap balance can be achieved. In conclusion, compared with the traditional TKA, computer-assisted surgery secure precision, which is more accurate and easy to perform. Besides, accurate bone resection required less soft tissue release. And I believe with longer operation of the prosthesis survival rate, we can perform a TKA more precisely in the future. Thanks for your attention.
Thank you, Professor Huang, for your wonderful case. I see some ideas, example for restoration of a native joint line, less soft tissue release that you and Professor Hao have in common. And we can focus on those in discussion later. Now let's welcome Professor Zhang Guoqiang to bring us a brand new surgical technique. I've heard about it, but I don't know enough. I can't wait to learn more about it. You can start your lecture directly. Professor Zhang, please.
Good evening, everyone. Welcome, Professor Howell. It's my great honor to be here to present my topic. My topic is medial restoration technique for total knee arthroplasty. My name is Guoqiang Zhang from General Hospital, of PLA in Beijing. As we all know, people are paying more and more attention to satisfaction in the development of total knee arthroplasty. The picture on the left shows the increasing number of articles on satisfaction surveys after knee arthroplasty in recent years. However, the degree of satisfaction after knee arthroplasty has not improved substantially and has always remained at a dissatisfaction rate of 10 to 20%. Post-operation dysfunction is one of the main reasons for low satisfaction, especially the limited function and pain when going up and downstairs and getting on and off the car. Let us review the mainstream technique currently in use: measure resection and gap balance. These two techniques are all based on the mechanical alignment concept. The target of the measure resection is obtain a balanced joint space by osteotomy equal to the thickness of the prosthesis combined with appropriate soft tissue release. The target of the gap balance is determine the thickness of femoral osteotomy based on appropriate soft tissue tension and the equal gap between flexion and exception. However, the reality is the thickness of osteotomy and the prosthesis are often inequality and lead to the joint line elevated. There are some reasons caused to the inequality, including using mechanical alignment concept to perform total knee arthroplasty and doesn't consider the cartilage thickness. The third reason is cannot to take into account the osteotomy of all parts at the same time. Let us look at the mechanical alignment concept. Its target is creating a rectangular gap by bone cutting perpendicular to the mechanical axis of lower extremity. We can see after operation, the joint line has changed from oblique to the horizontal, and the medial condyle wasn't replaced by prosthesis equally. As a result, the medial joint line elevated. The second factor is cartilage. Actually, most surgeons tend not to keep an eye on influence on a cartilage wear on the thickness of osteotomy during operation. Different cartilage wear may lead to 2 to 4 millimeters alteration of joint line. This is the most common thing on the medial condyle distal femur. As to the posterior condyle, there are also some factors affect the thickness of osteotomy. Just like we usually use mechanical alignment to perform the total knee arthroplasty, and usually use anterior reference to place the measuring guide. Different design of the measuring guide of external rotation osteotomy we usually select. We also use the gap balance technique to do the operation. Just like distal femoral cut, the posterior femoral cut is parallel to the transepicondylar axis, but it doesn't parallel to the joint line. So the thickness of the bone cut isn't inequality to the prosthesis. Gap balance technique has the same situation. In addition, when the AP diameter of the femur is just between two sizes of the prosthesis, if we use anterior reference to place the cutting guide, the posterior bone cut will be thicker. The different design of the measuring guide of external rotation also affect the posterior condyle bone cut. There are 3 different designs of the measuring guide being used now. They are used to adjust external rotation angle by center point, by medial condyle, and by lateral condyle respectively. Some papers indicated different osteotomy thickness occurred by using these 3 kinds of guide. This video just show you the lateral condyle. Based on the above analysis, even if we performed total knee arthroplasty by standard technique, concept, and the instruments, the joint line is still elevated. We indexed all the publications related to the joint line. The average elevation is about 3 millimeters. Once the joint line increasing more than 4 millimeters, the KSS function score will decrease. This is our clinical study. The results show elevation of the joint line was more obviously on the medial side. The elevation of the joint line not only reduces the range of motion, but can also cause the following problems, such as anterior knee pain, decreased range of motion, patellar baja medial flexion instability, patellar tendon impediment, accelerate wear. Some papers indicate raising the joint line is associated with mid flexion laxity. This table just shows when the knee joint flex at 30-degree flexion and 60-degree flexion, the joint laxity is bigger. This is intraoperative video during operation. We recut the distal femur. In full extension and 90-degree flexion, the joint is very stable, but at 30-degree and 60-degree position, we found some laxity on the medial side. So the elevation of the joint line can cause subtle instability and a paradoxical anterior translation. This makes patient not confident in high functional activities such as going up and down stairs. In addition, so many studies have confirmed that the medial side and the lateral side of the knee joint are unbalanced, and the medial side is more stable and the lateral side is more laxity. This picture just shows the medial side is very stable when we do perform the varus and the valgus stress test. So mid flexion laxity on the lateral side is more prominent, medial side more stable and constrained. This is a native knee. We can see on the lateral side more freedom, mobility, more glide. On the medial side, more constrained, more stable, more medial pivot. This is native knee. We can see on the lateral side, this more freedom, more mobility, more glide. On the medial side, is more constraint, more stability, and present medial pivot. Especially medial femoral condylar, it's maintain medial joint line, maintain ligament tension, and its main structure of medial pivot. Based on the above research and analysis, we proposed a new concept, medial restoration. Restore original structure of medial condylar of the femur, restore medial joint line, restore ligament tension of the medial side, stability at full of range of motion, and acquire natural medial pivot. Based on the new concept, we modify current operation technique. For distal femoral resection, we need to take into account the thickness of the cartilage, cement, and the curve. For the proximal tibia, tibial resection, we perform 0 to 2 degree varus bone cut according to the patient MPTA, and increase 2 millimeters additional bone cut. For the posterior condylar resection, whether measured resection and the gap balance, it is necessary to ensure that the thickness of the medial condyle equals to that of prosthesis, and adjust the tibial slope according to the extension flexion gap. Generally, tibial slope is 0 to 3 degree. These some pictures intraoperation. We use the caliper to ensure the accuracy of the bone cut. This is intraoperative video. After implanting the prosthesis, the knee is very stable. at full of range of motion. We also use robot-assisted total knee arthroplasty. We found that the knee joint present medial pivot movement from extension to flexion, although the prosthesis we used isn't medial pivot knee design. This is some X-ray postoperative. We can see after operation, the joint line just perpendicular the gravity axis. So almost every patient can walk actively at 4 hours post-operation. This is some patient, the video. They can walk freedom. Just 3 days operation, post-operation. For after 6 weeks follow-up, the patient can go up stairs. So she is very confident. So this is another patient. She can walk up stairs and stand up from bed. So many patient has acquired high functional activities. So in summary, we use the new concept to perform total knee arthroplasty, just focus on the restoration of medial condyle structure and avoid mid flexion instability. During operation, we adjust other bone cut to acquire better range of motion and the medial soft tissue tension. Intra-operation, we limit and no release medial soft tissue and maintain a regional soft tissue tension on medial side. We also use smart tools to assist bone cut and the soft tissue balance accurately. Thank you very much.
Thank you, Professor Zhang. Thank you. Today's 3 speakers. After listening to 3 great talks, I feel that there are some common elements in your ideas. That's you all show enough respect for the anatomy, kinematics, and soft tissue tension of the native knees when performing artificial joint procedure. Probably that respect is the key element for the improvement of post-operative outcome and patient satisfaction in total knee arthroplasty. At last, I would like to thank Arthroplasty Society in Asia for providing us the opportunity to participate in this online seminar. Okay, everyone, let's go with the day. Thanks for watching. Hope you all will enjoy yourself. We will see you next time.